So without further ado, I'm going to turn this over to Marci Nielsen, again, our CEO here at the PCPCC, and Nwando. And Nwando is the Associate Director of the UCSF Center for Excellence in Primary Care. So Marci, it's all over to you.
Thanks so much, Amy, and thank you everyone for joining us this afternoon on our briefing. This is terribly exciting for us to be able to share our annual report with you. And I did want to say in advance, in case you can't hear me, please do send an email to us in the webinar format. I think many of you are already familiar with the way in which we construct our webinars, but there is a webinar chat function that allows you to send us questions. If you can't hear me or you have any trouble with technical difficulties, please let us know through that webinar chat feature. And I might also mention, as Amy mentioned earlier, we do intend to give you a brief presentation and then open this up for questions at the end of the webinar, and that will also be the means by which you can send questions into us and we will answer them. So apologies in advance for coming to you live from the airport, but I think many of you have walked in these shoes before. So the results are in, as Amy mentioned, an overview of the key findings from the PCPCC's annual report are quite positive. If you go to the slides, what you will find is a list of the authors. We were very pleased this year that Wando has joined us for the first time as an author. Again, we have Paul Grundy and Kevin Grumbach joining us, and then a special section that talks about what's happening in Vermont and the multi-payer initiative, Lisa Dolsky-Watkins for us. One thing that changed this year from past years is that we have been trying to highlight the findings from patient-centered medical homes from both the peer-reviewed literature and the industry literature. But this year there is, in fact, so much information, a rich set of data that came from the peer-reviewed world, that we wanted to make this year's report a bit more rigorous and add more of an academic analysis of our work. And so we have a number of reviewers that you'll see and I don't see that the slides are numbered here for you. It's slide number 4. A number of reviewers who have worked with the PCPCC in the past. So for all of these slides, I don't intend to read them for you. I know you're tuned in on your webinar, but we are extremely grateful to not only the authors who helped develop this report, but to those reviewers who took the time and gave us terrific feedback on how to strengthen the report. And you'll see the list of those on slide 4. Excuse me. On slide number 5, we wanted to describe for you a little bit about the methods that we used to do this study. And as you might imagine, this being our annual report, we've had 3 previous reports that pointed to the evidence around patient-centered medical homes. And so we wanted to take a snapshot in time. We looked then at the peer-reviewed articles as well as the industry reports from August of 2012 to December of 2013. So we're looking at a little over a year. And what we found when we looked only at those studies that examined either medical home or PCMH model of care and then looked at the triple aim outcomes, we found 20 studies that qualified. For those of you who are academicians, we used then as the predictor variable medical home or PCMH, and those outcome variables that pertain directly to the triple aim. So cost and utilization first, care experience second, and the care experience we quantified from an access and patient satisfaction perspective, and then health outcomes, both population health as well as preventive service measures. If you move then to the next slide, slide 6, there were 13 peer-reviewed studies that met the criteria that I just described to you. You can see these are from all over the country. Some being national studies, for example, the military health system and the Veterans Health Administration, but to some smaller studies, for example, the WellPoint analysis for the New Hampshire Citizens Health Initiative, or a look at what's happening in Utah or in Colorado. If you move to slide number 7, we did find 7 industry-generated reports that qualified. And I might just say here for a moment, obviously the peer-reviewed studies we were able to find on PubMed, and those were fairly clear-cut in terms of being able to access the study and download them. For the industry reports, we were a bit more challenged in finding all of those reports. They needed to show up in a Google search engine for us to be able to find them. We did look a few other places, but I mention this only to say that I know that there are probably a handful of additional industry reports that would have met our criteria, but just didn't find their way into a Google search engine. So after looking at all of these studies and trying to organize them in a way in which we as the public would be able to ask and answer the question, does the patient-centered medical home actually work? Does it meet the triple aim? We find key point number 1, and of course the PCPCC is quite happy about the findings, and that is that PCMH evaluations did in fact report, when you look across a broad range of clinical and financial outcomes, positive findings. And what we did here, and I hope all of you were able to download the full report and or at least look at the executive summary that we sent out earlier as part of the announcement for this webinar. We have a slide number 9, that summarizes what we found on the peer-reviewed side, as well as a summary of what we found on the industry-generated side. And I'm just going to highlight those findings for you for a moment. If you break out the number of different outcomes that were measured across all 20 studies, and you categorize them according to the triple aim, you'll see in slide number 9 that for cost and utilization, we had significant numbers of studies that reported cost reductions or reported fewer emergency department visits. So 61% of studies finding those cost reductions, 61% reporting fewer emergency department visits, just 31 reporting fewer inpatient visits, and then another 13% reporting fewer readmissions. Now, a point of clarification here. We, for this study, did not cherry pick only positive findings. What we did is we looked at all 20 studies, and if there was a finding that comported with the triple aim, we included it in our analysis. It just so happened that almost all of the results that were reported both in the academic journals as well as in the industry reviewed reports were positive. When there were inconclusive findings or no findings, we obviously didn't include them in our tables. But in those places where there were negative findings, we did include that. And so our analysis here in slide number 9 on the peer-reviewed findings, when we say we found 61% of studies reporting cost reductions. I did want to clarify that those aren't cherry-picked numbers. If they looked at cost reductions in the vast majorities of studies that examine cost, they in fact did find a reduction. In only 1 out of the 20 studies were there no findings, and we include that in our table. Back to slide number 9 then. In terms of care experience, we measured care experience through two measures. One, whether or not access to care was improved, and we found that reported in 31% of the studies. And then we looked at patient satisfaction. There again, we weren't cherry picking the studies here. If they measured patient satisfaction, we reported it, and 23% of the studies both reported patient satisfaction and found patient satisfaction to be improved. Then the final triple aim outcome that we looked at pertain to health outcomes, and there were two ways in which we categorized health outcomes. The first related to preventive services. So we found 31% of studies reporting an increase in preventive services, and then another 31% reporting improvements in population health. And I'm going to stop here just for a minute and check in with Amy to make sure that you all can hear me okay. Are you all right?
Yep, you're still good, Marci.
Okay, terrific. Moving on to slide number 10 then. The PCMH industry-generated outcomes. So this slide looks very similar to the last slide, except, of course, it's focused on those studies that came from industry. You'll see slightly fewer, 57% of studies reported cost reductions. Another 57 reported fewer emergency department visits. But we found far more reporting inpatient visits had decreased. So 57% reporting fewer inpatient visits. And we also found in the industry reports that more studies reported on readmissions. So that was the good news in terms of contrasting industry with academic studies. On the care experience side, however, the industry was less likely to report improvements in care experience. Only 14% of those studies reported on an improvement in access to care, and again, only 14% reported improved patient satisfaction. I'm going to come back to that in a moment. In terms of health outcomes, very similar to the findings that we saw from the academic reports, roughly 30%. So what does all of this mean? Well, a good study would first reflect back on some of the challenges to doing the study itself. And anyone who has looked at studying the patient-centered medical home quickly realizes that there are challenges when we're looking to understand the differences and similarities around patient-centered medical homes because, of course, as they like to say, if you've seen one patient-centered medical home, you've seen one patient-centered medical home. What that means for us is that there are challenges when we're comparing apples to apples and oranges to oranges, and we observe some of those challenges, and then we make some suggestions in our studies. First and foremost, we ask ourselves if we're actually using the right metrics. Are we counting and measuring the right things when we're assessing whether or not medical homes, quote unquote, work? I think the major gap that we saw was that the vast majority of the studies didn't measure clinician satisfaction at all. It doesn't mean that there aren't studies out there looking at whether clinicians, physicians, nurses, et cetera, are happy with this model of care. There are, but those studies are being done in isolation. And what we're looking forward to is a time in which we've got core measures that measure all of the triple aim experience every time they're analyzing a patient-centered medical home and whether or not it's working. And so major gap is we're not asking ourselves questions about clinician satisfaction. And Wando can speak a little bit more to that given her years as a physician providing care to patients in a medical home model of care. Secondly, while we're encouraged that we did see increased patient satisfaction for those studies that measured patient satisfaction, it's clear that we aren't uniformly measuring that when we're looking at cost and quality. And in addition to looking at measures of the care experience, we make an argument that we need to look more than just at some measures of patient satisfaction at a 60,000-foot view, but we also need to ask patients about their own health status and well-being, how their mental health is, whether or not this model of care is making any difference in that regard. We believe we need to be thinking carefully about measures that look at patient diversity when, for example, we're measuring care experience and access, and we're looking at measures that involve e-health consults and using the internet. We need to keep in mind that not everyone has access to that kind of technology. And so you'll see a reference to that back in the report. Wando may also want to speak to that. And then finally, as I mentioned earlier, we are interested in thinking about core measures. Every time we measure a medical home, what should we be asking ourselves when we're assessing whether or not this model of care works? And I think there is a real dearth of understanding about how we can integrate behavioral health into the patient-centered medical home and what measures we ought to be using to do that. I know a number of folks are looking into this, and AHRQ and others are making some recommendations, but the reality is none of the 20 studies that we looked at in a little more than a year talked about behavioral health integration as part of the triple aim experience of care, and we think that is a significant gap that we need to spend some time as an organization being focused on. You'll also see we ask ourselves some questions about the right methods. The target audience for this particular report isn't necessarily academicians and researchers, but it's policymakers, payers, clinicians, and others. But it's important for them to understand that when academics ask us a fair question, which is, does this model of care actually work? Or are we still at a point where we say that the data is inconclusive? We need to take a step back and recognize we're not just measuring, for example, whether or not a pill is effective or not effective. Measuring whether a medical home works is a far more complicated endeavor. The model itself evolves over time. As I mentioned, it is implemented differently in different medical settings. And so we need to keep in mind, as we're asking ourselves about the model, that the model and the philosophy is evolving and should continue to evolve so that it can best meet the needs of patients and their families. Two more key points then that I will make that we make in the study before I turn it over to Wando. You'll see key point number 2 is when you look back at these studies and you think about what's next, what not only from a research perspective and how we continue to evaluate this model, but what is the role that patient-centered medical homes will play in the health transformation, the ongoing health transformation of the future. What you quickly recognize is that the accountable care organizations that are working and getting shared savings and making an impact in their broader communities nearly always have patient-centered medical homes and at a very minimum primary care playing the foundational role in that community. You cannot, we would argue, you cannot have a well-functioning accountable care organization without building that ACO on a foundation of medical homes and primary care, and we found that when we looked across the studies. But we can't just limit ourselves to the clinical care setting. When you look at slide number 13, for example, you see we've got a model of care on the right that is focused on the clinical aspects of health care delivery. But when you look to the left and you see we list community centers, public health, schools, employers, faith-based organizations, the YMCA would be included there, for example, or Meals on Wheels. What are the other kinds of community organizations that do important work in terms of keeping a population healthy? And this, too, is a place where patient-centered medical homes play a very critical role in linking people, individuals, consumers, into the clinical world that you see on your right, but also back into the community on your left. And then I'll point you to slide number 14, which is the fact that if, in fact, this is the model of care that we find demonstrated evidence for and real excitement about from patients and families to clinicians and the payers who have embraced this model. We've got to be willing to make payment reforms that pay for care differently. And by that, I'm not inferring that we've got a lot of new money to spend in this country or at the state level for healthcare. We need to be paying differently for healthcare. And so we talk about the patient-centered medical home, the reason for investing in it, but we point to the challenges of a fee-for-service system that incentivizes volume, not value. We talk about the importance of alignment across payers and the importance of projects like this, like the CPCI, the primary care initiative being advanced by the Centers for Medicare and Medicaid Innovation. And we talk about the real optimism that we have around the sustainable growth rate fix that moves us away from a fee-for-service system and incentivizes patient-centered medical homes, care coordination, team-based care, accountable care, et cetera. That reform is imperative. As many of you no doubt know, Congress is looking for a pay-for that legislation. Senator Wyden has introduced new legislation that also embraces concepts around the patient-centered medical home as a means to help folks with chronic illness. So we're quite optimistic that we're going to make some real headway there. Then we provide a number of snapshots that I'm not going to go into details on, but starting with slide number 17, some of the studies that we took a look at as part of our analysis. We provide you with a bit more information and some of the strategies that each of these organizations embraced as they implemented patient-centered medical homes. And with that, I'm going to thank you for joining us to get a briefing on the report itself, and I'm going to invite Wando to give us some commentary as one of the authors, as a physician who's worked for many years in a patient-centered medical home, federally qualified health center. You see I've got my take-home points on slide number 22, but Wando no doubt has her own take-home points, and then we'll open this up for questions and commentary from the folks who are on our webinar. So Wando, over to you.
Great, thank you, Marci. And thanks to all who are participating in the call. I wanted to just make a quick comment about me, and I appreciate Amy's introduction earlier. As stated earlier, I am a family practice physician and currently work as the Associate Director of the Center for Excellence in Primary Care at UCSF, but prior to that had served as the Chief Medical Officer of Connecticut's largest federally qualified health center, which had 12 medical sites throughout the state of Connecticut. And I was responsible for transforming those medical centers into patient-centered medical homes, making that organization one of the first to have both Level 3 recognition by the NCQA and the Joint Commission Primary Care Medical Home distinctions at the same time. And one of the things that I would just like to point out about the process is that really the transformations are definitely doable, and they're possible, and they're real, and they're happening all over the country, as you can see. And it was really exciting for me to be part of this process, to participate in the development of this report and looking at all the data that has been done regarding this effort, because I think that we definitely all agree that this model and this type of transformation is essential to delivering good primary care in this country. But in many places, and even being a frontline physician and a medical leader, I definitely had to answer a lot of questions about does it make sense? Have we proven that it works? Are there any clinical benefits? Are there financial benefits? And so it's very exciting to see that this has come out and that we've found significant benefits in different areas. So I know their questions are coming in through the webinar, but Amy, maybe if you could provide one of the questions that has come up so far.
Yeah, and in fact, we've gotten lots of questions. Marci, you might be the best one to answer this. Can you talk a little bit more about how we group the data in the report? So, for example, if 61% of the studies showed cost reductions, does that mean that 39% showed no cost reductions, or that they just didn't measure costs?
Thanks. That is such a good question, Amy, and it's come up before. No, that means that 39% of the studies did not measure cost savings. Instead, what they may have measured is utilization. So the best way to get a quick feel for what the studies found or didn't find is to go to tables 1 and 2, and you'll see the findings that each of these studies reported was characterized according to the triple aim categories that I outlined earlier. And if 61% found cost savings, it just meant that 39% didn't measure cost savings as part of their study. And thanks for that question.
Thanks, Marci. Since we're talking about costs right now, can you talk to whether or not any of the reports that are included in our report, any of the studies, talked about where those cost savings went? Did they direct them back to the primary care practices? Did they go back to health plans? Did any of them specifically talk about how they dealt with those cost savings?
No, and I would point to the UPMC study that out of all 20 studies did the deepest dive into describing their analysis of the cost savings, both in terms of their investment, so what they literally had to spend in order to implement the patient-centered medical home, and then what they found in terms of the cost savings. And again, we highlight that in Table 1. None of the studies go into any detail on how they used those savings and invested back in the practice, or exactly how they chose to deal with the savings. But it's a really important question, not just because, as I point out in our third sort of key point, we need to make these investments and change how we pay for care, and of course the fact that these sorts of endeavors do in fact require some investment. But it's part of key point number 2, which is when we try to make changes to our model of healthcare delivery in isolation. In other words, if all we were doing is trying to change primary care, but not also coupling those broader payment reforms and delivery reform changes in isolation from the rest of the broader medical neighborhood and accountable care, we're in some ways just reinforcing the silos. What we know for those accountable care organizations that have invested heavily in primary care, the shared savings that come back to providers are in fact far more attainable than when organizations are working in silos. Now, I would say the evidence on all of that is still fairly early. As most folks know, we've got lots of activities around ACOs happening in the private sector, but the Medicare ACOs are still fairly new. And I would say that where we really ought to be focusing our attention on this question in particular, which is where do you make the investment? Where do the shared savings come back to? How do we use those dollars? Is really around the CPCI initiative, the Comprehensive Primary Care Initiative, because we are tracking those multi-payer initiatives quite carefully. We've only really got the first year of data in the door, and so I suspect that we will learn a lot more about the best ways to invest those savings. But the total cost of care that the UPMC model analyzed really needs to be the standard in many ways if we want to understand how we save money in the overall healthcare system while still improving the quality of care delivery and improving on health outcomes. Wando, you may want to say a little bit about where, as you implemented the model as the primary care physician, or even in the academic research, where we're making investments and where we still see some gaps.
Sure. Yeah, absolutely. One of the areas that we certainly recognize, and as was alluded to in the report, is that the understanding of the satisfaction and experience of the clinical teams that are delivering the care still is an area that is ripe to be explored. And from my experience, one of the major costs is not something that is easily quantified, but it's what we call the hidden cost of transformation. And as you change paradigms and add additional responsibilities to the members of the care team, or revise their roles and change processes and workflows, you can certainly expect that there are staff that don't really embrace those changes very well and will turn over or struggle with the concept of assuming more responsibilities. And one of the things that I did as the chief medical officer was to make sure, as we were trying to implement new processes to become patient-centered medical homes, that we would have a strategy to, we would call it shift work to and shift work away. So as you're going to add more responsibilities to the primary care physician or nurse practitioner or physician assistant, it would be important that certain other responsibilities that they had would be shared among the members of the care team. But it's very hard to actually quantify what that looks like and what the costs are of the turnover or the disengagement of clinical teams if that happens. So I definitely agree that those trying to get a better handle on what are some of those costs and how do those changes impact the staff is very, very important. And then additionally, I would just say that any kind of staff disengagement or dissatisfaction or discomfort with transitions like this certainly impact the care of patients. And so again, another place that we hope will continue to be important in any evaluation of such transformations is really the voice of the patient and how patients experience their care and what the differences are in their experience as these transformations are going on and after.
Thanks, Nwando. We've got a question that I think would be great for you to respond to as well. Can you talk a little bit about the different members of the care team in a medical home? What disciplines do you include? And a follow-up question to that was, are you aware of any teams that have included therapists, such as occupational therapists, physical therapists, speech therapists?
That's a great question, and I would say for now that I don't think there is a right answer to that. And so the area of team-based care and sharing the care is really growing. And I most commonly have seen the clinicians, physicians, nurse practitioners, physician assistants, nursing staff, medical assistants, behavioral health providers, pharmacists, receptionists, a number of these different staff members being parts of these teams. And rehabilitation therapists, such as occupational therapists, physical therapists, speech language pathologists, I think also play a very important role. And whether it's within the medical home itself or in the larger context of the medical neighborhood, I'm not sure exactly. It depends on probably the organization's resources and access to those highly skilled other members of the care team. But I do think that getting the medical home right within the walls of the primary care space will enable the medical neighborhood and the larger sets of players in it to communicate better.
Another question that I think follows up really well to what you just described. So knowing there's not a one-size-fits-all model, how do medical schools and residency programs teach to the patient-centered medical home, teach to this model of care, because when there are so many variations?
I think what is probably most useful at the level of professional and paraprofessional education is really shifting the mindsets. And I don't think that you can give a recipe for exactly how do you teach people to be in patient-centered medical homes and practice that. But the whole emerging field of interprofessional collaborative education and practice models is really important in this area, because it is, for some of the providers who have been largely at the helm of practice efforts and workflow design efforts, being able to give up some of the responsibilities that they have is a challenge. And one of the areas that I experienced during my work in this area was in the fact that the physician staff would say that they were becoming less autonomous in these transformations, but still maintain the same level of responsibility, accountability, and medical legal risk in the care of patients. And so how do you reconcile that? So I think just starting to teach people about what does it mean to work in a team, and how does a team share roles and responsibilities, and how all of these various members of or potential members of the care team have very unique strengths and talents and skills that they can add to the delivery of care, and honestly to lessen the burden ultimately on any one person, but to share it among the members of the care team. But I think that will be that there will have to be a lot of shifts in the way care is reimbursed, because if you're reimbursed for the direct patient care and the physician or provider component of a visit, but you're not reimbursed for the calls that the nurse is making after the patient leaves, and the medical assistant calling another specialist to be able to get the information back from a visit, then people see that what they're reimbursed for as what is important. And so I think that this will also have to have some shifts in reimbursement as well.
And I would just add to that, Amy, I would underscore the same points that Wanda's making, but I would also point out that expanding health professionals' team experience in both undergraduate medical education and residencies is really important. We think more about residencies being a logical place to encourage team-based care, but as we shift undergraduate medical education and all the health professions shift to this model as well, just exposing students early on to other health professionals, whether it's in a clinical setting or whether it's just sitting together in a class, I think is important. And some of the changes that we need to make need to move us away from so much training inpatient and doing more training in an outpatient setting. And that's I think ubiquitous in terms of needing to make that shift across the system.
Great, thanks. Marci, here's a question for you. What's been the response from health plans and employers to this report? Are they looking at this data and now establishing more PMPMs for care management or paying for care coordination codes? Are there other financial investments that they're making in primary care, seeing that the cost savings and the improvements of quality are there?
The answer. It's a little soon to say with great confidence. What we do know is that both health plans that have already invested in this model, but health plans that are also looking to invest in this model, are very interested in the data, and so they appreciate having this report. They use this to talk to their employers, especially employers who are self-insured and who are struggling with their own implementation efforts around the Affordable Care Act, and now they're looking at health delivery reform and want to know whether or not this is an investment to make. A study like this that demonstrates cost savings is really important to them, and so I would say I'm going to give an optimistic yes. We hope that this study, this particular report, encourages those employers and payers to invest in this model.
Great. And there's a few questions too. Can you elaborate a little bit more on how cost savings or decreases in costs were analyzed? Were they total costs of care? Were they costs just related to utilization? Can you describe it in a little more detail?
Sure. So the way in which cost savings were measured was quite variable across studies. Again, I would point folks back to the report and table number 1 or table number 2. The very first column that quantifies cost savings, there was a number of different measures. As I'd mentioned, UPMC was the only study that measured total cost of care and broke out both the investments in what they had to pay to create a patient-centered medical home model, and then what the costs were, and of course their return on investment that they list there, which was pretty significant. Other studies, it was quite variable. Some of them just mentioned cost savings from a global sort of return on investment perspective. Others drilled down to savings from ambulatory sensitive emergency room use. I've got unfortunately, I can't access the internet from this airport, so I don't have the report here in front of me. Folks need to look at those tables to see the various ways that they measured cost savings.
Thanks, Marci. So in regards to the report, were there any findings that were actually negative? So did any of the studies that were included have increase in costs or even neutral costs, and did any demonstrate any decrease in quality of care?
So on the cost of care side, none of the studies found an increase in the cost of care. One study, the study in New Jersey, did not find cost savings. We note that in table number 1, but that particular study only looked at 12 months worth of data. And so no, there weren't any studies that said they didn't find any cost savings at all. They just didn't report it.
How about the actual? Oh, go ahead.
Yeah, I was just going to say, and I'm sorry, what was the rest of that question, Amy? I'm furiously trying to get my iPad to pull this up so I can give you specific examples. Oh, there was one other. I'm sorry, you'd asked the question. There was one other study that had a negative finding. That was the military health study. They found a decrease in the number of inpatient admissions, but they found an increase in the number of days in the hospital. And so how they, and I was able to pull this up, and so that was sort of interesting. And so this was under the Military Health System Initiative. Having said that, they found a 6.8% fewer emergency department visits. To your earlier question, Amy, which was about what are the other ways that cost savings were measured, again, wanting to point folks back to the study itself. But for example, WellPoint, who didn't give us the methodology, but when they looked in Colorado, they estimate that they got a 2.5 to 4.5 return on investment from every $1 invested. The Blue Cross Blue Shield Michigan folks, with full PCMH implementation, they found a savings of $26.37 per member per month. That was marginally statistically significant. But it really sort of spans the gamut how every study measured cost savings. And again, it's one of the reasons that it's going to be important for us to have these standard core measures over time and across studies. And you had another question, Amy?
Yeah, another question is related to the actual populations of patients that were studied. So did the studies look at total populations by practice? So how were they attributed? And then did some of them look specifically at disease-specific populations, those with multiple chronic conditions? Someone raised the question or made the comment that some medical homes only enroll their sickest population to really focus on and provide this extra enhanced level of primary care. Did any of the studies look at more specific populations, or were they total populations?
So if they only looked at a specific population, we actually didn't include them in the study. There was a terrific study of federally qualified health studies that looked only at diabetic patients, and so we didn't include that in our particular study. But to the questioner's point, there was real variability in how each of the studies analyzed the medical home model itself. So what you'll see, for example, if you look at the first study that we cite in table number 1, the Military Health System PCMH initiative, what they did in their analysis, even though they're moving all of their patients into a patient-centered medical home model, when they did the analysis, they separately analyzed those with chronic conditions from all patients. And we provide the outcomes based on those categories. Everything that you see included in our table was directly taken from each of the studies themselves. We didn't try to recharacterize or reclassify what the authors studied, and so that's how the military health system study did its analysis. But if you looked at, for example, WellPoint in New York, WellPoint analyzed a set of patients and had a comparison group, and so each of the analysis that they include is compared to a control group, which we then also include in our analysis. There were some studies that were pre and post test. For those of you who are researchers, you will know that's not as a rigorous an evaluation tool, pre and post, as a case control study is. There was only one randomized clinical trial that was included here, and we note that. We try to provide as much information on each of the studies as you can put into a table and in a snapshot. But for folks who have specific questions about the study themselves, you'll need to go back to the reference and look up the study, and you can get more information. I might also just parenthetically point out Meredith Rosenthal, who is a researcher at Harvard, is just beginning her work on a meta-analysis of a similar set of studies, and she will be diving in to a number of those methodological questions that we didn't dive into here. This study was meant to look at the triple aim outcomes.
Thanks, Marci. Nwando, I think I've got a good question for you. So looking at this data, how can an individual practice make the business case, the argument to say, I really need to enhance my care team. I need to hire someone who can do care coordination or integrate behavioral health. How can I create a business case if I'm not part of a large integrated health system, or if I'm not a part of an ACO that has some shared savings and some way to get revenue back from the larger cost savings?
Well, I think that it's a great question, actually, and I think it's very, very important to just recognize that some of the transformation that we're talking about is costly, and in either financial terms or in human resources. But I do think that it's possible to I won't say do this in a cost neutral way, but I would say to work with what you have, and there are a lot of states that are moving towards reimbursing through Medicaid and also the Medicare demonstrations to actually reimbursing practices for the efforts that are spent on care coordination activities, and whether and the range for what the reimbursements are varies across the different states, but there is some recognition already that it's important to provide financial incentives and support around this area of work. But in the absence of that, and even independent of that, I think it's also important to work with the teams that you have and start to, do workflow mapping and analysis and understand who is playing which role, and are the roles that people are playing the right roles for them. What are you using the technology that you have or implementing efficiently, and is it becoming a tool as opposed to an extra thing that's impeding your ability to give good care? And are there other people that don't necessarily seem to always be part of the care team per se, but that play a huge role in being able to help with these transformations, such as human resources? Or can you engage people in those areas to train staff or to revise job descriptions and establish competencies and things like that? So there's definitely a lot of possibilities working with what you have to do some of the changes and the transformations within a practice setting, but also to the extent that you're able, making sure that you're in communication with the people that pay the bills in the states to also finance some of this work.
Thanks, Nwando. kind of in reference to that question a little bit, I think there's a question asking on the average size of the panel. So when you're seeing practices transform to patient-centered medical home, are we seeing that the panel size typically increases or decreases, or I think maybe how the work might be shared across teams, but what's been your experience?
Yeah, I don't know if I have an answer to what the trends are. I mean, I think that there are pretty good estimates on the amount of the number or the panel size that a typical primary care provider should be handling and taking care of. And there are places where, you know, the addition of other members of the care team and sharing the work and maybe prioritizing patients that see certain members of the team may allow for them to take on new patients. But I don't think I have an actual answer for what the right number is or what the ideal number is. And I would say that there are practices do a number of different things to be able to accommodate that. So again, when you're adding capacity, maybe it does allow more patients to be able to access that system, but I couldn't say that that's consistently or consistently seen across the board.
Sure. And I would just underscore Wando's point that there's been some research that's looked into this, and it's highly variable. It not only depends on the team first and foremost and who's on your team, but it also depends on your population of patients and how sick they are, what their social needs are. And so I think some of the early evidence around huddles and teamlets demonstrate that you're able to actually take on more patients, but I don't think we necessarily have seen that consistently.
Thanks, Marci. And in reference to teams, I've got to say we've gotten so many questions, way more questions than we have time to answer today, about who comprises the team. Lots of different questions related to different disciplines that might be added, how many, panel size, all of that. So we certainly do have some resources up on our website that can answer some of those questions, but Marci, I think it's time to do another webinar. We'll have to schedule another webinar talking about who's on the team in the patient-centered medical home. But in closing, I want to offer you both an opportunity to respond to this last question. And again, my apologies to everyone on the audience if we didn't get to your question, but I think this might tie things up kind of nicely. How can we use this data to build the argument for how we can improve linkages between the medical home and community-based organizations?
Well, I might just go first and tell you what the trends are and what the research tells us, and Wando can speak to that as well as her own personal experience. I mean, I personally am interested in the patient-centered medical home model of care because it's the first truly innovative, exciting, and embraced across multiple constituencies. It's the first model that I've seen that ties public health and the community to clinical care. That's where I just see such tremendous opportunity. Folks who have never thought of themselves as being a health provider, certainly not a health care provider, now see themselves as being a part of this movement potentially, and that's tremendously exciting and important to me. But I think it's also really paradigm shifting for consumers. I mean, when we're in a clinical setting, we're patients, and we follow the lead of the clinician, the physician, and we're compliant or we're not compliant. In a world in which we are coupling public health and community health together with clinical care, now we're, I think, also empowering the patient, and they get to have a far greater impact on who is on the team, so to speak, based on who's in their life. Are they a student? And so school-based care is part of the team. Are they somebody who is a strong member of a faith community? And so the church is a member of their team. I mean, this is really very dependent on an individual maximizing their own health based on how they live their life and what they value. And so how do we get these community-based folks into this space with us? One, we welcome them, we explain this, we value them, we invite them to our meetings, we invite them to be our members, we do outreach. I had a fantastic meeting with the CEO of Meals on Wheels who hadn't heard of the patient-centered medical home, and when I got done explaining it, she said, we're totally part of the PCMH. So from a community activist perspective, it is the most exciting thing to me about the potential of this model. Wando can speak more about how that actually works in a grassroots setting.
Yes, thanks. I agree entirely with Marci. That was very well said. The only thing I could really add to that is that although the process of making change and changing paradigms is somewhat challenging and can be challenging, I really do think that we are really looking at a model that people want and people will embrace. And when I think about the kind of care that I want my children to have and my parents to have, having people that know and understand them, care for them in a continuous way, make themselves accessible to them, and are communicating with so many other people that are taking care of them. I think that's really the holy grail of healthcare, and I feel that it's what we would want and expect for those that we care about and those that we love, and it's also very much an opportunity to have a central figure, a central place that is responsible for shepherding the rest of the neighborhood. And so I think that it's a very nice time to be able to look at these and see how we can better facilitate these transformations in the small and medium and large practices that have very different needs in places that are geographically different, with patients from very different socioeconomic or racial and ethnic backgrounds, but being able to plan for the costs that are associated with this as well. So it's very exciting, and I really look forward to seeing how we can continue to prove the concept in terms of cost and clinical outcomes, but also be able to understand the experience of patients in these settings and experience of the clinical teams.
Great. Well, thanks so much to everyone who participated on today's call. Certainly, thanks to you, Marci, and to Nwando for the presentation and answering all these great questions. We will have this presentation archived up on our website by next week with a copy of the slides. So if your colleagues were not available today to participate in the live version, please do direct them to our website. Again, thanks to everyone who participated today, and we look forward to hearing you on our February monthly briefing. Again, the last Thursday of every month is our monthly briefing, and we'll have registration up very soon, and we hope to see you all back again. Thanks so much, everyone. Bye-bye.